So it's my pleasure to start this session with a more technical aspect or practical aspect about the transpulmonary pressure. So I'm glad I will not have to give too much of theory, but more of how to do it at the bedside in your own ICU. This is Toronto. This is my conflict of interest, and one of them is that I'm leading the working group called the Plug for Pleural Pressure Working Group, a very successful working group of the Society of the Acute Respiratory Failure Section. And we have a meeting tomorrow night from 7:30 to 10:30. We are so excited that we are able to meet at any time of the day or the night. So we already, with the group, put together conference and then a position paper, which I think is interesting for everybody who wants to apply the technique in the ICU. The reason why we want to measure the pleural pressure, so using the esophageal catheter as an estimate of the pleural pressure, is double. The first one is because the pleural pressure is the pressure surrounding the alveoli, and because we matter so much about the real distending pressure of the lung, which may cause harm to the lung. Just looking at the airway pressure, the pressure on the ventilator is not sufficient. And there are a lot of data, which I'm not going to show today, showing that if you really want to estimate in the individual patient what is the distending pressure of the lung, you need to have the measurement of the pressure on both sides of the alveoli, so the airway minus the pleural or the esophageal pressure. That's what we call the transpulmonary pressure. The other reason why one may be interested to measure the esophageal pressure is that it is the only way to capture what the respiratory muscles are doing when they are active, and to quantify what we call the work of breathing or the different indexes of patients' respiratory muscle effort. So very useful to approach the risk of ventilation and the quantification of patients' effort. To do that, you need equipment, and you need some kind of device to measure the pressure in the esophagus. Fortunately, we do have a number of devices available, and some of them are now coming on the market specifically designed for ICU purposes, so not only, for instance, laboratory testing. And this is one of the new devices, which is a nasogastric feeding tube. So instead of the usual feeding tube, you have this one, which have two balloons, one in the esophagus, one in the stomach, and you have radio-opaque marks, which help you on the X-ray to know whether the two balloons are positioned below and above the diaphragm. So this kind of catheter is very useful, but there are other on the market. This is from a recent study done by Francesco Maggioli, or you see the different brands, and I'm sure there are other on the markets. Some of them are just standalone catheter. Some of them are linked with a measurement device. Some of them are even linked to one specific ventilator. So that's the good news, that more and more technique systems are available on the market. It may be even simpler in the near future to measure esophageal pressure by using simply a liquid-filled catheter, like, for instance, a suction catheter that you would insert in the esophagus. And this study suggests that if you measure at the same time the esophageal pressure with a balloon, with a liquid-filled catheter, or with an air-filled catheter, so you see the three were attached at the same time to make sure that you measure at the same place. The result of the study strongly suggests that they can probably be as good as the balloon catheter. There is more cardiac oscillation on the balloon catheter, which is one of the ways to recognize that you are in the right place. But in terms of the amplitude of the pressure, this study suggests either during controlled mechanical ventilation, so when it's passive insufflation, or during spontaneous breathing, that this technique could be used to replace the balloon catheter. And that would be very nice because then everything would be completely similar to an arterial line catheter, for instance. You just use exactly the same equipment than for a vascular measurement. Then the insertion by itself of the catheter, then the correct placement, needs some expertise, needs some training. It's not obvious at the first time. As for any technique, you need to learn and train a little bit. I think once you have done maybe something like 5 measurements, you become to be comfortable. But the first ones you need to do with somebody. And here we have described one way to do it, which is to insert the catheter as far as possible. And for instance, this is a catheter with an esophageal and a gastric balloon, and you have the recordings of the airway pressure and the flow, the signals from the ventilator, and the esophageal pressure and gastric pressure. And you see the first recording indicate positive deflections on the gastric balloon, positive deflection on the esophageal balloon, which means that the 2 balloons are below the diaphragm, because when the diaphragm is contracting at every breath during pressure support ventilation, there is a positive deflection. So that's good. You're too far. Maybe you have been inserting the catheter for 40 centimeter, for instance. So you remove gently the catheter until you start to see negative pressure swings on the esophageal catheter. That means that you are now in the esophagus and you're measuring the negative pressure swings due to the activity of the diaphragm. And in this example, for instance, the pressure support level was even slightly decreased to better see the signal on the esophageal pressure. So that's a way to put the catheter in the right place. It's not finished because to be sure you have a reliable signal, you need to do what is called an occlusion test. What's an occlusion test? It's very simple. It's the comparison of the esophageal pressure signal and the airway pressure signal when you have no flow. So this is an example when the patient is spontaneously breathing. This is an example when the patient is passively insufflated. When he's spontaneously breathing, you occlude the airway with a pause on the ventilator, and the esophageal pressure negative swing should be very, very similar to the airway pressure negative swing. Why it should be similar? Because the difference between the two, which is called transpulmonary pressure, should remain 0 because there is no change in volume. If the patient is not spontaneously breathing, you can do the same thing by gently compressing the chest. And then you see the rise in esophageal pressure, which should have the same amplitude as the rise in airway pressure. So that's the technique. And when the ratio is not good, it may be that you did not inflate the balloon sufficiently, or it may be that it's not exactly in the good position. So that's the kind of thing you have to learn before starting this measurement in the ICU. Then you need a monitor. You need to display the signal. You may have your own monitor equipment, but the good news is that it's very easy to use the hemodynamic monitor at the bedside and to connect even the air-filled balloon catheter to the vascular transducer. And you see here, for instance, the tracing of esophageal pressure. You just have to remember that this is displayed in millimeters of mercury, whereas when you read the pressure on the ventilator, this is displayed in centimeters of water. The night is falling, no? Yeah, good. So that's not so complicated, but you need to think about it if you want to do that in the ICU. What we do in our own ICU, for instance, is we use a small transport ventilator, transport monitor, which is dedicated to this measurement. So we just bring it at the bedside, and this is an example of a patient with passive mechanical ventilation. So you see the positive pressure swings of the esophageal pressure. You see that the amplitude is approximately of less than 5 millimeters of mercury, so it's not large amplitude. You need to have an appropriate scale. And this is an example of a chest compression. So we freeze the screen, we measure the amplitude, and we compare to the same measurement on the ventilator screen, the airway pressure. So nothing very complicated, but a lot of small details which need to be learned before introducing the technique in the real life. One of the major interests today is about ventilation of patients with ARDS. And in that situation, you have two approaches. One is to simply look at the change in transpulmonary pressure during mechanical ventilation. So I took this paper because you have these nice tracings of airway pressure, flow, and esophageal pressure. And you see that an additional small detail is that you have sometimes a lot of cardiac oscillations, and you have to be sure that you take the signal always at the top or the bottom of the cardiac oscillation to measure the amplitude. This change in transpulmonary pressure, or here in esophageal pressure with the tidal volume inflation, will help you to differentiate the part of the airway pressure distending the lung and the part of the airway pressure simply moving out the chest wall. And this is an example of two kinds of patients in terms of chest wall and respiratory system elastance. And you know, elastance is pressure over volume. So when we look at elastance, we look at pressure for a given volume. And these are patients where you have the respiratory system elastance, which is almost entirely explained by the lung elastance, which means that most of the airway pressure, for instance here the 25 centimeters of water of driving pressure, are distending the lung, because only maybe 5 centimeters or even lower of water are moving out the chest wall. So in this kind of patients, you would say, well, most of the airway pressure is really pressure at risk for distending the lung, so I must be very careful in this individual patient. By contrast, these are patients who may have abdominal distension, obesity, and other chest wall disorder, and you see that a large part of the total elastance, so it's the same driving pressure, is due not to lung distension, but it's simply moving out the chest wall. So in these patients, you would say, well, even if my plateau pressure is already relatively high, I'm still in a safe range, and it's possible to increase PEEP, for instance, because I need it, instead of deciding for another approach for my patient. This is the same kind of tracings, and in this case, what you simply need is just something like a plateau pressure on the esophageal pressure to measure the delta, the change during tidal inflation, and this will be very easy for you to calculate how much of the airway pressure is distending the lung or is moving the chest wall. The other approach which have been proposed during ARDS is to look at the absolute value of the esophageal pressure at end expiration. Why the absolute value? Because the reasoning is that at the end of expiration, if pleural pressure is higher than the alveolar pressure, in other terms, is higher than the PEEP you have set on the ventilator, the transpulmonary pressure will be negative, and this will, of course, favor collapse of the lung. And this was tested in this clinical trial by the group in Boston, Danny Talmore and Steve Loring, and they tried to adjust the PEEP to make sure that the transpulmonary pressure, so the difference between airway and esophageal pressure, was positive between 0 and 10 centimeters of water at end expiration. So this is the kind of tracing they got with the airway pressure. You see here a plateau, the esophageal pressure, the same plateau, and then the direct difference between the two, airway minus esophageal. So this is the transpulmonary pressure. And in this case, they adjusted the PEEP close to 16 or 18 centimeters of water to be sure that the PEEP was higher than the absolute value of the esophageal pressure at end expiration, so that the transpulmonary pressure was positive at end expiration. So this is great if the measurement is reliable. And we have a lot of data to show that the change in esophageal pressure, once you have done the occlusion test, are really very reliable. We are less sure that the absolute value is reliable. And these are, for instance, recent data obtained by Francesco Moggioli, just showing in an in vitro study that if you look at the pressure, this was measurement of pressure in a box. Depending on the volume injected in the balloon, you may underestimate the real pressure if you don't put enough volume in the balloon, or you may overestimate the pressure if you put too much volume. And the difficulty is that the amount of volume in the balloon may depend on the absolute pressure you measure. So the higher the intrathoracic pressure, the higher should be the injected volume in the balloon. But then the next issue is that if you put too much volume in the balloon, you may have a reaction of the esophagus, some contraction, which may overestimate the absolute value. So maybe it works, but we are not sure, and that's why this group is doing clinical trials with this approach to see whether it will lead to a better outcome. I will stop there and be happy to answer any question. Thank you very much.